afternoon, honorable judges, my dear teachers, dear friends, ladies and gentlemen. Me SIAM Al MOBARAK from Bangladesh. Today I am very glad to present you a case presentation about coronary artery disease. Okay, a male patient, 43 years old, he admitted our hospital August 1st, 2016. His chief complaint was repeated chest pain for 1 year. On August 2015, that means 1 year before, he had been experiencing substernal chest pain, which lasted for 10 minutes, but it was not a radiating chest pain. He admitted to another hospital, that's called Rikhan Hospital. The doctors in the Rikhan Hospital, they did the angiography with 2-stent right coronary artery, and after 1 year, that's in August 1st, 2016, the relapse of chest pain again, and he admitted to our hospital. Past history, the patient smokes more than 10 years, and a history of hypertension and type 2 diabetes mellitus, and the recorded highest blood pressure was 180 by 110. That means it was so high. And physical examination, except the blood pressure, all kinds of vital signs was normal. The blood pressure was 150 by 110 millimeter mercury. 1 year ago, PCI in Rikhan Hospital, the first PCI. This is the first picture. It shows the proximal left coronary artery stenosis about 60%, and the second picture, it shows middle right coronary artery stenosis and distal right artery blockage. And the following two pictures, it shows like the stent in the middle right coronary artery and distal right coronary artery. And this is the final picture after the stent. So it shows like the hematitis of black clot. This is the secondary prevention therapy which is given by Rikhan Hospital doctors. So aspirin and clopidogrel 1 year for the antiplatelet therapy. Metoprolol succinate till the patient came as beta blocker. Peridropil they use to reduce the hypertension. Atorvastatin calcium 40 milligram only for 1 month, and later they reduce the dose to 20 milligram until the patient becomes sick. And patient have diabetes mellitus, so due to diabetes mellitus, they use Acravos until the patient came to the hospital. And this is the echocardiogram. This is done by a hospital. So it shows hypertensive heart changes. And this is the ECG. It shows tear changes. And this is the lab findings in our hospital. Patient's white blood cell it increased little bit. Platelet also increased. Patient's troponin I was normal. So that means the patient didn't have recent myocardial infarction. Third, patient's BNP was also normal. So that means patient doesn't have recent cardiac failure. And this is the fasting glucose level. So that means the drug for diabetes also works very well because it is in the normal level. And this shows normal liver function and a normal kidney function test. And this is LDL-C is also 1.630. It's also quite good. So diagnosis. So what is the diagnosis? Diagnosis was coronary artery disease, unstable angina pectoris after PCI, and very high risk grade 3 hypertension and type 2 diabetes mellitus. is the PCI done by a hospital. So this is the first picture. It shows patient have left LAD stenosis about 80%. So that means the situation become worse than 1 year before. And this is the second picture. It shows the Ruthann Hospital stent works very well. Although there is a little bit stenosis in the distal coronary artery. And this is the third picture. It shows the stent, the balloon, in the left coronary artery. And this is the final picture. It shows normalize of the blood flow. Okay, why is stenosis? Anyone have any idea? Okay, let me tell you. First, the patient smokes. So, after doing the PCI 1 year before, the doctor suggests that don't smoke, stop smoking, but patient didn't listen. So this is one cause. And another cause is the doctors use first 1 month high dose statin therapy, but after 1 month they reduce the dose. It is 20 milligram 4 times a day. Okay, the New England Journal of Medicine, it shows like high intensity statin therapy, it should be 40 milligram to 80 milligram to control the lipid level. There are several guidelines to show the risk of the cardiovascular events, like our treatment target goal. Okay, we use this inhibitor, but there should be a target level. The target level is if the patient's lipid level is so high, at least we should try to continue 70 milligram per deciliter, or if his cholesterol level is uncontrollable, at least we will try to reduce more than 50% to reach our goal. Okay. Amlodipine is the CCB, which is the first line drug of choice to control hypertension. So when the patient came August 1st, 2016, after he came, we give his drug, and after 7 days we see his blood pressure become normal. So that means the drug works very well. And this is the secondary prevention medication is given by our hospital, aspirin and propiconazole for antiplatelet activity. After the stent, we should use these two drugs. And metoprolol succinate as a beta blocker to reduce the heart rate and also to reduce the blood pressure. Spainropil also reduce the blood pressure. I already explained amlodipine. I already explained atorvastatin, calcium, 40 milligram. So 4 times a day. So that means it is high intensity statin therapy, acravos, to control the diabetes mellitus. Thank you everyone, and special thanks goes to my teacher, Miss Long Mai Yin. Although she is not here, she is in Beijing, but last 1 month she was helping me to prepare this PPT. And in the absence of her, today my teacher, Lu Bebe, she came here to support me. Thank you.
Okay, thank you for excellent presentation. Mike. So, what are risk factors for CAD? Risk factors.
CAD risk factors if patient smokes for a long time, diabetes mellitus, and hypertension.
Anything else?
And cholesterol, if it's too much fat, it also can causes the risk factor. That's in diet.
So, how about the family history?
The family history for this patient, he had no family history. And it's also a risk factor, yes. If your parents or brother or grandfather have the hypertension, you might get this disease.
Okay, thank you.
Okay, very good lecture. I'm sure you have prepared this PPT for a long time, and your teacher, Professor Long, have give you some instructions. And something I want to know, just, according to your PPT, firstly, about 1 or 2 years ago in Raycom Hospital.
1 year ago.
1 year ago.
Yes.
Okay, one stent. Two stents were implanted in right coronary artery. And at that time, just 60% stenosis in LAD.
Yes.
And at that time, in Raycom Hospital, LAD, the patient has undergone PDCA in LAD? No, okay. So at this time in our hospital, there is stenosis in RCA? RCA, no.
No stenosis, but it is the distal area, distal artery, distal right coronary artery stenosis. It's very little bit.
Just more serious stenosis in LAD.
Yes, that's why we treated this.
So at that time, in your PPT, you mentioned with stenosis. So not
Restenosis means like the patient right coronary artery distal area restenosis become there
a little bit.
Okay.
Okay.
And we also use drugs to control the lipid level and also to control the antiplatelet platelet activity. But we are using drugs, but why left coronary artery become more narrow? So that means there are some problems.
Okay. What do you think about the satisfied serum level of LDL-C, the target?
Target should be, I already explained, like it should be at least
Lower than
70%, or if it is uncontrollable, at least we will try more than 50% to control the cholesterol level, LDL-C.
LDL-C. Could you tell me the accurate number? Lower than how many millimole per liter?
Laushi, I already the PPT. You can see. This is the level. This is the normal level.
Lower than which level is satisfied? It doesn't matter.
Laushi, it should be 1.8.
Yeah, very good.
1.8.
Lower than 1.8. Very good. It is correct. Lower than 1.8 millimole per liter. And so here I just emphasize that just this patient, the serum level of LDL-C just 1.6. Actually, it is satisfied.
Yeah.
So the pathological lesions in the coronary artery still progress.
Yes.
Not only because the lipid level, because
But also this smoking.
Smoking, yeah.
Because
you're
the
right.
smoking, the nicotine becomes narrowing the artery.
So not only the lipid level, smoking does harm to the coronary artery. Okay, very good. Any questions from the audience?
I want to ask you, what are the side effects of CCB, that is calcium channel blockers?
Okay, the side effects of CCB, if we use, it can reduce the it can increase the heart rate, and also it can do the lower edema, lower extremity edema. Okay.
Contraindications of clopidogrel.
Contraindication for clopidogrel, like if the patient have ulcers, if the patient have any blood clotting problem, or maybe he have the problems like how to say, like brain edema due to the maybe like how to say this, but this is like blood clotting in the brain, like aneurysm, and mainly clopidogrel, the function is antiplatelet activity, and if there's some blood clotting problem, so the platelet, so they may be the platelet like it don't clot well, so there should be like the blood cannot be stopped, so more blood goes.
If the patient is contraindicated to clopidogrel, then what are the side effects?
If the patient is contraindicated to clopidogrel, we should stop this drug until the patient becomes normalized.
I want to ask a question. Why the coronary artery has no stents?
Because left coronary artery, it is supplying the most part of the heart. So that means if the if the blood lipid level is more, so that means it is supplying more. The blood viscosity is more. So plaque is going there, and platelet is also like it's clotting that place, and it's making stenosis.
Thank you. Wow.
Next one.
How about just 3 questions that because
Here I emphasize that actually amlodipine have little effect in increasing the heart rate. Almost no effect in increasing the heart rate. Doesn't like nifedipine. So amlodipine usually does not affect the heart rate. Does not affect the heart rate. I emphasize that. Verapamil may reduce the heart rate, and nifedipine may increase the heart rate, but amlodipine seldom affects the heart rate.